Oops. Okay, class, this is part 2 of the respiratory system. See if I can get through this without making a bunch of mistakes here with my new drawing pen that I still am not used to. So we're going to pick up where we left off. We kind of left off at the larynx. So before we move on to the trachea, we'll just do a quick review of the larynx and see what you remember. So this cartilage structure that is sticking up here in the anterior view, and you see it in the posterior view, this is made from elastic cartilage. This was called the what? This was the epiglottis. The epiglottis goes down and covers our airway. When we drink or eat food, they call the epiglottis the guardian of the airway because it's guarding our airway. That's the epiglottis. The next cartilage we have is this guy. This is the thyroid cartilage, and the thyroid cartilage does not go all the way around to the back. That's the thyroid cartilage, and this area right in the middle, which kind of sticks out, is the laryngoprominence, aka the Adam's apple in men. And the thyroid cartilage is made up of what type of cartilage? It's hyaline cartilage. And then we have one other cartilage that we need to talk about, this guy down here. Now he's in the front, but he also extends to the back here. This is the cricoid cartilage. So cricoid cartilage is the cartilage, and it makes a ring around the entire airway. That is also made of hyaline cartilage. Oops. And once we get down distal to the cricoid cartilage, we are going to be starting, this is going to be where the trachea starts. And we talked about these C-rings, these cartilage C-rings. They're C-rings because they make a C. They do not make a complete circle. They are not O-rings. They are C-rings. Oops. And there's going to be a space in the back here. So these cartilage rings do not go all the way around to the back. They have a space back here. The esophagus is going to be back here, and we'll look at that in a little bit. So let's see if we can get to our next picture. Just wanted to bring you this model. This is the classroom model. Here you can see the hyoid bone. Here is the thyroid cartilage. Here is the thyroid gland. And then you can see the C-rings of the trachea back there. Here is the trachea here too. And behind the trachea is going to be the muscular tube. This is the esophagus. The esophagus is taking food down to the stomach. But I wanted to show you the relationship of the trachea to the esophagus. Make sure you know the esophagus is deep to the trachea. So here is the trachea model. We have the larynx up here, and then we're going to have the trachea start right here. So the trachea in adults is about 4 inches long. Not that you need to know that, but just for some reference, it's 4 inches long, and it's about 1 inch in diameter. So pretty big diameter. And it has these tracheal C rings about 16 to 20 tracheal C rings. These are the tracheal C rings, 16 to 20 of them. And we have these tracheal C rings made out of hyaline cartilage to keep this airway open. If we didn't have these cartilage C rings, every time you bend your neck, fall asleep in class, you'd obstruct your airway. So it would not be good. So that is the trachea. It's basically just conducting the air that we breathe, and it's going to be sending that air down and go into the right and left lungs. So it's just conducting air down. So I wanted to show you, here is just a drawing of the trachea. So here we have the C ring of the trachea. So this is our C ring. It's hyaline cartilage. In the back there is no cartilage. Here's the lumen of the trachea. And what kind of epithelial tissue is lining the trachea? Respiratory epithelium, which is pseudo-stratified ciliate columnar epithelium with our goblet cells, so our mucus secreting cells. And here's the actual histology, so we can actually see here's the hyaline cartilage C ring. Here is going to be where the esophagus is, back in here. So here's the lumen of the esophagus. It's going to be lined with non-keratinized stratified squamous. So when you eat food is going to go into the esophagus. And if you see how collapsed the esophagus is, and if you have a big ball of food because you didn't chew properly, and it will actually stretch and it can push that into the posterior wall of the trachea. So that's why you're not having a complete C ring around. So if you do swallow a big clump of food, it will have room to push in into the backside of the trachea. And the other thing I want you to know, starting from the trachea, it's important because it has actually, let's see what color am I going to get here. Good. It has, the trachea is going to have smooth, okay, why didn't it get it? It's going to have some smooth muscle in here. And that smooth muscle is going to continue all the way down into almost all the tubes that are leading to down deep into the lungs. Smooth muscle, remember, is controlled by who? Smooth muscle is controlled by who? The autonomic nervous system. The parasympathetic is going to contract smooth muscle, and the sympathetic nervous system will dilate the smooth muscle. That will be important. So let's see, what do I have next? Here is a nice histology slide. So this is going to be the lumen. The lumen is lined with what kind of epithelial tissue? PSCC with goblets. This is hyaline cartilage. I don't know if you can tell on this mag, but this is your C ring of hyaline cartilage. Whoa! How did I do that? I pushed some kind of button. Let's see if I can get back. Oh my God. I'm there. Oh my gosh. So that was our C ring. And okay. I need to go back to my pencil. Sorry. This was our C ring of hyaline cartilage. The trachea is lined with PSCC. On the posterior wall is going to be where the esophagus is, back in here, so food's going to go down here. Air is going to go down here. Pretty good so far? Here's a close-up. This is going to be PSCC, pseudostratified ciliated columnar epithelial tissue. Here's going to be our smooth muscle. Got a ring of smooth muscle. And here is the C ring made out of hyaline cartilage. Same thing, respiratory epithelium, which is what kind of epithelium? It's always going to be PSCC, and here is the C ring of hyaline cartilage. Here is a slide from the classroom. Here you can see the cilia. Can you see the cilia? Here's the lumen right here, and here is cilia. Here's our PSCC. There's going to be some smooth muscle here. And here is our hyaline cartilage. That's going to be our C ring. So pretty easy, right? Boy, I sure have a lot of these pictures. So I guess that means you need to know that the epithelium on the respiratory epithelium, where it's conducting air, is going to be what kind of epithelium? Pseudo-stratified ciliated columnar epithelium. Got it? Now, at the distal end of the trachea is going to bifurcate. Bifurcate. It's going to split. And there's going to be some cartilage plates right here to reinforce it. But this area where it bifurcates, this is going to be the carina. Carina. So we are going to send a tube. This is the left side, and this is the right side. So we're going to send this tube right here is going to go to the left lung, and this tube is going to go to the right lung. And these tubes are called the right and left primary, write this down, primary bronchi. Right and left primary bronchi. We're just going to abbreviate primary like that, primary bronchi. That is the first split. They are going to their respective lungs. This one's going to the left lung, this one's going to the right lung. And if you just look at the anatomy of it, if you have a swallowed object that is going down the trachea, you swallowed it, not good. It's normally going to get lodged in the right primary bronchi because it's a little bit fatter and it's more of a straight shot to get to that right primary bronchi. Remember, bronchi is the plural, bronchus, C-U-S, bronchus, B-R-O-N-C-H-U-S, bronchus is singular. So this would be the left primary bronchus, right primary bronchus, and these are the right and left primary bronchi. plural. Got it? So I wanted to show you, this is our classroom model again. Now, when you look at the lung, this is the left, make sure I'm on the pin. This is the left side, this is the right side, and you can see the lungs, right? Let me change the color here. This is the left lung, and it has a little cutout, a little notch right here. This is called the cardiac notch. See where it kind of curves in? The cardiac notch. That's only on the left side to accommodate the heart. Heart is on the left side. And we see a fissure. There's going to be a fissure here. This is the oblique fissure. And it's separating the left lung into two lobes. This is the left upper lobe and the left lower lobe. So that's the left lung. Now on the right lung, you're going to have this fissure, which is called a horizontal fissure, and this fissure, which is an oblique fissure. And we have three lobes on the right side. We have the right upper lobe, the right middle lobe, and the right lower lobe. And the other thing you need to know is something called the apex. Remember, we have a triangle. The apex is the top part, the base is the bottom part. Well, in the lung, this top part is the apex, and this bottom part is the base. The base rests on the diaphragm. So apex, make sure you know the apex is there. Apex and base, the bottom part of the lungs. Now before we go, let's see what's next. Let's see what picture's next. I guess we could do this and then I'll do something after this one. So once again, here's showing you the apex. This is the left lobe. This is the cardiac notch. This is the oblique fissure that's separating the two lobes. Two lobes of the left side. Here is the horizontal, the horizontal fissure, the oblique fissure. On the right side, we have 1, 2, 3 lobes on the right side. And in the middle, the medial aspect of both lungs, you're going to have this collection right here. A collection of the primary bronchi that go in to each respective lung, and the pulmonary arteries and veins that are entering and leaving the respective lung. That is the hilum. So the hilum is this area where we have the blood vessels entering and leaving the lung, and the primary bronchi leaving and entering the lung. That is the hilum. You must know what the hilum is. Let's see. Now I think I'm going to draw. Let's see what's next. And I'm going to draw you something before I get to this part. So I'm actually going to pause this for a second. So before we go on, I just want to go over the serous membranes of the lung. We talked about the serous membranes of the heart, the visceral and parietal pericardium. And remember, serous membranes are made up of what kind of epithelial tissue? Remember, simple squamous, simple squamous. So the serous membranes are simple squamous. And what was the special name of the simple squamous that forms our serous membranes? So the simple squamous, what was the special name of the simple squamous that forms our serous membranes? Mesothelium? Remember that? Mesothelium? So you hear those advertisements for call your lawyers for mesothelioma if you've been exposed to asbestos. Mesothelioma. That is a tumor of the mesothelium, and if it has to do with asbestos exposure, it probably is the serous membranes of the lung. So let's draw our, see what color do I have here. This red's going to be okay. So we are going to first do our visceral pleura. So the visceral pleura, remember, is right on top of the lung, right on top of the lung. You cannot really pull it off. And then it's going to go up, and then where the hilum is, where the primary bronchial tube comes in, it's going to curve around on both sides, and it's going to form what? That was the visceral pleura, and it's going to form what? The parietal pleura. Remember that? The parietal pleura. And then in between them is what? Is serous fluid. So this is the serous fluid, the lubricant. Remember, the lungs move, so you're going to have a frictionless environment here that's surrounding the lungs. And this is a potential space too. So this is the pleural cavity. It's a space. It has a thin amount of serous fluid, but it can also collect things too. It can collect fluid in here. If there's some kind of infection or disease process of the lung, you can actually get fluid collected in this cavity, and it will start pushing on the lung, and you can get a collapse of the lung. You can have some kind of injury to the lung where you puncture the lung, and if you puncture the lung, there could be air escaping out of the lung, and it's going to go, every time you breathe, there's going to be some air going into this space, and that air is going to start compressing the lung too, so that lung is going to potentially get real small. It's called a collapsed lung. So usually if you have something going on with this pleural cavity and it's collapsing the lung, you're going to have to put a tube in there, a chest tube, to drain out either the fluid or the air so that lung doesn't get compressed and collapsed. So I just wanted to draw the serous membranes of the lung. Make sure you remember them. Parietal pleura is the outside one. Visceral pleura is the one that is directly attached to the lung. Oh, where am I? Okay, now we're going to go back to this picture. And we said that this is going to be the left side up here. So this is the left, this is the right. Now we're into what we call the bronchial tree. Now the bronchial tree is just these bronchi. We had this is going to be our left primary bronchus, and this is our right primary bronchus. And now we have how many lobes on the left side? Get a different color here. We have 2 lobes on the left side. So this is going to be a secondary bronchus. Secondary or lobar. Secondary or lobar. Lobar. bronchi. We have how many on the left? We have 2. Lobar means going to the lobe. We have 2 lobes on the left. We have 3 lobes on the right. So here's going to be our secondary lobar bronchus. There's 1, 2, and 3. So we have 3 secondary, aka lobar, L-O-B-A-R, bronchi on the right because we have 3 lobes. So far, so good? Yes. Let's see I'm not sure what I have next. I might stop and draw something else for you, but let's see what I have next. I can show you this, and then I'm probably going to draw something too. What color do I have? Let's do a brighter color. So here we have the primary bronchi, right and left. Here's right, here's left, and then we're going to have the lobar, the secondary, and then they're going to start splitting. Once we get down here, we just see them splitting, and they get smaller and smaller. They call it the bronchial tree. The bronchial tree. Once we get to, they're just going to split, and it's going to get smaller and smaller. So it does kind of look like a tree with all its branches splitting. And what you're going to notice, starting from the trachea, we have what? What are these? We have cartilage. Cartilage. To keep the trachea from collapsing, that cartilage continues down into the primary bronchi, the secondary bronchi, and see all these little areas here? This is all cartilage. So we have cartilage all the way through here. All the way through. So if it says bronchi, it doesn't matter how small those bronchi are, they are going to have cartilage. The other thing that all bronchi have, they're going to all have PSCC with goblet cells. So they all have respiratory epithelium, and they're going to have smooth muscle. Smooth muscle. And they all have cartilage. So they all have PSCC, they all have smooth muscle. Oops, that should be a 2. And they all have cartilage. From the biggest, which is going to be the primary bronchi, all the way to the end, where we call it something called a terminal bronchi, not terminal bronchi, all the way to the end, they are all going to have PSCC, smooth muscle, and cartilage. So I'm going to stop this because I'm going to draw something for you, and then we'll come back, right back, but let me pause this for a second, if I can pause it. Okay, so I'm kind of drawing this to hopefully this will make more sense. So here we have the trachea right here. So here's the trachea, and the trachea is going to bifurcate or split, and we're going to form this is the right side, this is the left side, right and left. This is going to be the right primary bronchi, left primary bronchi, and then we're going to have, on the left side we have 2 lobes, so we're going to have 2 secondary bronchi, secondary bronchi, aka lobar bronchi. And on the right we have 3 lobes, so we're going to have 1, 2, 3 branches. 1, 2, 3, and those are going to be the secondary bronchi. And from the secondary bronchi, we're going to have a split of 3. This is going to be the tertiary. That means 3. Tertiary. I'm just going to put 3. 3. Splits 3 times. You kind of see a pattern here. Splits 3 times here. Then we're going to have a 4th order of a split from each of these. It's going to split 1, 2, 3, 4. So that's a 4th order. And then from there, it's going to split 5 times. 5th order. So what's going to happen, you're going to have these primary bronchi, and it's going to split secondary, tertiary, whatever 4 is 4, let's put 4th order, and it's going to split all the way down to 23 branches, 23 orders of splitting. So it's going to get smaller and smaller, but these are all considered bronchi. All of them are bronchi. From the biggest to the smallest, they are bronchi. What do all bronchi have? They all have, not that color, they all have PSCC with goblets lining their airways. That's the lining epithelium. They all have smooth muscle, so there is going to be smooth muscle starting from the trachea, smooth muscle lining all of these bronchi from the biggest to the smallest. So they're all going to have smooth muscle. So the autonomic nervous system could bronchodilate or bronchoconstrict any of these airways, right? So they all have smooth muscle. All bronchi all have smooth muscle controlled by the autonomic nervous system. Yes. Parasympathetic causes bronchoconstriction. It's going to narrow the airways. The sympathetic nervous system is going to cause bronchodilation, which is going to open the airways. And they all have one other thing. Do you remember what they all have? They all have cartilage. So all these airways are going to have cartilage. That is going to be important too. So all these airways, if it's a bronchi, they're going to all have PSCC, they're all going to have smooth muscle, and they're all have cartilage. What kind of cartilage? Hyaline cartilage. They all have cartilage, just to let you know. So far so good. So that's going to take us to go for a oops. Nope. Did not want to do that. Let me go there. Wanted to do that. That is going to take us, so we have all our bronchi. We got 23 orders of bronchi, 23 orders of splitting, right? Of bronchi. And then they're going to get so small, we're going to call them, another word, we're going to call them bronchioles. Bronchioles. Bronchioles are just little bronchi. Little bronchi. Let's see, what do I want to tell you about bronchioles? Once you are quote, a little bronchiole, your diameter, the diameter of your lumen, diameter is less than 1 millimeter. Pretty darn small. So bronchioles, they are tiny. Their diameter is tiny, less than 1 millimeter. What do bronchioles have? They have lost the cartilage. Lost cartilage. There is no cartilage. There is no cartilage on bronchioles. That is a big difference. No cartilage. They've lost or no cartilage. No cartilage. What else do they have? They still have smooth muscle. Smooth muscle. They still, what did I do? They still have smooth muscle. So they are still, in these tiny little airways, you're going to have bronchoconstriction and bronchodilation. And the other thing, these bronchi all had what? PSCC? These guys are going to start, they're going to switch from PSCC to simple columnar. They still have cilia. And these bronchioles are going to divide too. I'm not sure how many times they're going to divide, but they're going to divide multiple times till they get to really, really tiny bronchioles, and they're going to call it a terminal bronchiole. It's the last guy, terminal. The terminal bronchioles. They are the smallest bronchioles. Terminal bronchioles, these guys are still going to have smooth muscle. They are now going to have simple cuboidal. So they're just getting, those cells are getting shorter and shorter. Simple cuboidal. So terminal bronchioles. Then they, remember, no cartilage. So far so good. We got our bronchi that are going to, they've been dividing a lot. Then our bronchi are going to get so small, we're going to call them bronchioles. Their diameter is less than 1 millimeter. And these bronchioles have lost their cartilage. They no longer have cartilage. They still have smooth muscle. And their lining epithelium is gone from PSCC to simple columnar. They still have some cilia. And then finally these guys, these bronchioles, are going to keep dividing till they become to terminal bronchioles. And not that you need to know this, but their diameter is less than 0.5 millimeters. These are itty-witty guys. But they still have smooth muscle. So you can still get bronchoconstriction in these guys, and it would be hard to breathe if the parasympathetic nervous system was overactivated. So, terminal bronchioles. So far, so good. And let's clear that up. And let's go, let's see where, don't know where I am. Boop. I think I've already shown you this picture already. These are all bronchi because you can see cartilage plates, little cartilage plates on all of them. One other thing, here's the cardiac notch. But in here on the medial surface, this area right here, so here's the cardiac notch on the left side, but on the medial surface of each lung, where it goes in to make room for the heart, that area here on the medial surface of the lungs, each lung, is called the cardiac impression. Good name because it's where the heart is making an impression, bulging in on each side of the lungs. So just so you know that's on your master list, so you know what the cardiac impression is. So where are we? What's next? Yay! We are coming to our end of our journey. Yay! So we said terminal bronchioles. So here we have a terminal bronchiole. Okay, why is it not? What color did I got? I got green. It should be showing up. Terminal bronchioles right here. Remember, bronchioles have no cartilage. They still have smooth muscle. And the epithelium, lining epithelium, is more like simple cuboidal. And then this is what we call the end of the conduction zone. So the end of conduction zone. We talked about the conduction zone briefly. The conduction zone is just those structures that are carrying air from when we breathe it in all the way down into the lung, but there's no exchange of gases. So we brought our little particle of air all the way from our nose, and now we have come to the terminal bronchiole. That is the end of the conduction zone. The end of the conduction zone, from the nose to the terminal bronchiole. Now we are going to be starting our respiratory zone. Respiratory zone. The respiratory zone is going to be starting with the respiratory bronchioles. They are still tiny little bronchioles, but what they have are these little outpouches of alveoli. Alveoli is where we have gas exchange. So once we get into a respiratory bronchiole, which is right here and right here, we have these little outpouches of alveoli. Alveoli, site of gas exchange. Site of gas exchange. And what gases are we exchanging? We are taking in O2 in, CO2 out. So we're going to go from our respiratory bronchioles, which is here and here, and then we are going to be going into these areas. This is called an alveolar duct. Alveolar duct. And these alveolar ducts are going to take us into these clusters. Let me change my pen color. These clusters called an alveolar sac. So we got an alveolar sac here, here, here. And there's a little sac here. And the sacs are going to have all these clusters of alveoli. So the alveoli are all these little guys. Lots of them. How many of them? Around 300 million of them. 300 million alveoli in healthy lungs. So in both your lungs, you have approximately 300 million total alveoli for sites for gas exchange. Pretty cool, right? So just make sure you understand the difference between the conduction zone. Conduction zone is just conducting or transporting inspired air to, but there's no exchange of gases, and it's going to end at the terminal bronchioles. The respiratory zone is going to be starting with respiratory bronchioles. Those are going to go to alveolar ducts, and then the alveolar ducts are going to take us into alveolar sacs, where we have access to millions of alveoli. Pretty cool, pretty cool. I'm not sure what I have next, but let's see. Oh, here's a better picture than mine, but my drawing was my drawing. But so here we see a terminal bronchiole, and then we're going to go to the respiratory bronchioles. So this is going to be the end of the conduction zone. The respiratory bronchioles are the start of the respiratory zone. They have intermittent areas of alveoli. They're going to take us into alveolar ducts, the alveolar sacs, which have lots of alveoli. What else do you need to know? There is still a little bit of smooth muscle in the respiratory bronchioles. We definitely have smooth muscle in the terminal bronchioles. There's just a little bit of smooth muscle in the respiratory bronchioles. No smooth muscle once we get into the ducts and the sacs and the alveoli. I think that's it. And here you can kind of see, this is just what the lung histology looks like under the microscope. Nothing else looks like this. I would never ask you what this is. That's an alveolar duct versus respiratory bronchiole. I wouldn't ask you that. But all these little guys here, all these guys are alveoli. You can kind of see this is like a alveolar sac because it's got lots of alveoli around it. So what do I have next? Some more. This is actually a terminal bronchiole. You don't need to know that. But then you can see it going into a respiratory bronchiole here and here. How do I know that? Well, you see little pooches of alveoli every once in a while. And then it's going to be going into these ducts, these alveolar ducts, which are taking us into these little pockets of alveoli. This is alveoli sac. So here you can see a bunch of alveolar ducts going into alveolar sacs here. Hopefully you can see that. Another alveolar sac. And then we just have so many alveoli all through here. Millions of them. Beautiful, healthy lung. Now we're getting down to, they're just showing you a blown up one alveolus. This is one alveolus right here, made up of simple squamous, and every alveolus is going to be surrounded by capillaries. That's how we're going to have our gas exchange, right? We have air in here, but we need to get air, CO2, into our red blood cells. Actually, to carry O2 out, we need to get pick up some oxygen. Excuse me. We need to pick up oxygen and take it into our red blood cells. And we're going to get rid of CO2 so we can breathe it out. But we are going to pick up our O2 and from our alveoli, put it into our red blood cells, and get rid of CO2 so we can breathe it out. Simple squamous. Capillaries are also simple squamous. So what do you need to know? Well, remember we drew simple squamous like this in the classroom a long time ago. One layer thick, flat. The nuclei are flat. And then we had a little basement membrane. We had a basement membrane to anchor our epithelial cells. So if this is alveolar epithelium, simple squamous, and then we have our capillaries, what type of epithelium are capillaries made of? They also have simple squamous, right? Capillaries are nothing but simple squamous. And what's cool about these guys, where we have the alveolar epithelium interfacing the capillaries, the basement membrane of both of these guys is fused together. So this fusion of this basement membrane between the alveolar epithelium and the capillary epithelium, which is just simple squamous for both of them. Remember, capillary epithelium is endothelium. Endothelium is a special type of simple squamous, special name. And we have alveolar epithelium, which is also simple squamous. So there's this structure called the respiratory membrane. It's the fusion of the basement membrane of alveolar epithelium and capillary, the basement membrane of capillary endothelium, or simple squamous. So make sure you know what a respiratory membrane is. That is where we're going to have gas exchange. What is the respiratory membrane? It tells you right here. The fused basement membranes of the alveolar epithelium, which is simple squamous, and capillary endothelium, which is also simple squamous. What else is cool in here, you're going to see these guys, alveolar macrophages. Remember, macrophages are part of our white blood cells, right? What kind of white blood cell that's floating around in your blood, and then it leaves the blood to go into tissue, and it's called a macrophage? So if it's just floating around in your blood, these are called monocytes. But once these monocytes leave the blood and go into tissue, and here we're in an alveoli, they are called macrophages. So they are going to help protect you from any infection, any foreign invaders that might get down into this area. Let's see, what do I have next? I don't even know what I have next. Ah, muy bonita. Look at this lung. Healthy, healthy lung. It has 1, 2, 3 lobes. So what lung is this? 1, 2, 3 lobes. So the right lobe. This is the horizontal fissure. This is the oblique fissure. And look at this. Beautiful. Here's one single alveolus. Here you can see capillaries, and you see the alveolar epithelium. They are just kind of fusing together. Lots of gas exchange taking place in through here. Let's see, what do I have next? Well, here's a healthy lung. This is a smoker's lung. They look a little different, don't they? And what do we have next? Just to make sure you know the difference between the conducting zone. The conducting zone starts from your nose all the way down to the terminal bronchioles. This should say bronchial, terminal bronchial. So this is terminal bronchial. Oops. I'm going to show you that next. Terminal bronchial. Terminal bronchial. And then the respiratory zone is going to start with the respiratory bronchial. And that is going to go into an alveolar duct, alveolar sac, and then the alveoli. So I'm going to put alveolar sac in here. Alveolar sac. This is the whole alveolar sac that contains all the alveoli. Got it? So now we'll go to this thing here. So what I want it to do here is just go through, this is if you trace a drop of air and you're breathing it in through your nose, we're going to start through the nose and the vestibule. What can you tell me about the vestibule? What kind of epithelium is the vestibule? Stratified squamous? Yes. What does the vestibule also have? Vibrissae, little nose hairs. Nose hairs, the vibrissae. What's their function? To trap particles as you're breathing them in. And then we're going to go into the nasal cavity. The nasal cavity has what kind of epithelium? PSCC with goblet cells. Why do we have goblet cells here? Goblet cells make what? Mucus. Why do we need mucus? Because it's sticky. So any air particles that we breathe in, if there's something that needs to be cleaned, if there's dirt or anything in that we're breathing, it's going to hopefully stick to that mucus. And the mucus also is going to humidify the air. Remember, part of the job of mucus is to humidify air. And there is lots of blood flow in the nasal cavity, so the blood is going to, the blood flow, lots of blood underneath that PSCC, lots of blood flow, so the blood is going to warm our air as we breathe it in. So if we want warm air, especially if it's a cold day. Then we come down to the three parts of the throat, the pharynx. Nasopharynx, right behind the nasal cavity. What kind of epithelium? PSCC with goblets. Yes. Oropharynx is right behind who? The mouth. So the mouth carries food and drink. So this is going to be stratified squamous. The laryngopharynx is also carrying food and drink, and it's going to be stratified squamous. And once we get to the laryngopharynx, this common passageway, this carries food, drink, and air. The air is either going to be going into the larynx, which is air only, or it can go into the esophagus. But if we are air, so hopefully we are going to go into the larynx. The larynx has the epiglottis that's protecting the airways. So when we swallow, the epiglottis is going to cover our vocal cords. Remember your vocal cords? And we have the thyroid cartilage, hyaline cartilage, the cricoid cartilage, also hyaline cartilage, and our epiglottis, which is elastic cartilage. Then we're going to go into the trachea. The trachea has those C rings, hyaline cartilage, C rings, and the trachea is going to divide into the right and left primary bronchi, and then we're going to have the right and left secondary bronchi, aka lobar, aka lobar bronchi. Lobar means what? Means lobe. So how many secondary bronchi do we have on the right? We have 3. How many secondary or lobar bronchi do we have on the left? 2. Then it's going to branch, get smaller and smaller till we get to our bronchioles. Now remember, everything from the trachea everything from the trachea to these 23 orders of branching, when they're still called bronchi, everything that's called a bronchi has what? It has lining epithelium, a PSCC. It has smooth muscle. Got to know that. Smooth muscle. And also has cartilage. Remember, if it says bronchi, it's going to have all these 3 things. Once we get into bronchioles, these are our tiny, tiny air tubes, real small, our little bronchi. What's different with them? They now have no cartilage. No cartilage. What about their lining epithelium? The lining epithelium is going to go switch from PSCC to simple columnar. Simple columnar. Hopefully you guys are writing this down. I think this is on your worksheet, the last page. Simple columnar to simple cuboidal. But they still have what? All bronchioles still have what? Smooth muscle. Why is that important? Because a bronchoconstriction is going to constrict those smooth muscles, make those airways smaller, and bronchodilation is going to make those airways bigger. Remember, parasympathetic is bronchoconstriction, sympathetic is bronchodilation. Then we are going to leave. So everything above here was the conducting zone. So this is all the conducting zone. Conducting zone. And then everything below, this is the respiratory zone. Respiratory bronchioles, they are basically losing the smooth muscle, just an itty bitty amount, and we are now going to start finding pockets of simple squamous where we're going to have exchange of gas. So those respiratory bronchioles are going to go into, oops, bad. This should be alveolar ducts, and the alveolar ducts are going to take us into our alveolar sacs. My bad. And then those sacs are going to take us to clusters of alveoli. How many do we have? Over 300 million. This is the site of alveoli, or the site of gas exchange. So pretty simple, right? Do I have anything left? I know I have something else. Let me see. What do I have here? Let me see if I have anything else I want to show you. We're basically done, but I just want to show you some clinical stuff. Here's a normal chest x-ray. If you see black, that just means there's air. So you can kind of see the trachea. It's darkened. The lungs are basically dark because they're full of air. You can see the outline of the heart, the diaphragm. This is a normal chest x-ray. Normal lateral view Everything looks normal, nice clean black air here. So now that you know what normal looks like, actually you can see the trachea outline like this, can't you? There's the trachea. I'm not sure why it's moved over this way, but look at this. This is not normal. This is alveolar cell carcinoma. So the alveoli are cancerous. This is not. This is BAD. BAD, really BAD. Normal female, when you're looking at them, always don't get confused with this. This is breast tissue. They're symmetrical. So if you're looking at a chest x-ray of a female, you always want to make sure if it's female, they should be symmetrical, or ask if they've had a mastectomy, because that could change the appearance too. I think I already showed you that, normal lung. Here is pneumonia. This is an alveolus right here. There's another alveolus. Another alveolus here. But look at all this. This is like filled with neutrophils, bacteria. Hard to have gas exchange when it's filled with all this stuff. This is deadly. This can kill you. Here is emphysema. Emphysema usually, oops, go back. Emphysema is usually with, seeing it with smokers. They have destroyed a lot of their alveoli, so instead of having lots of little alveoli all over the place, they've been broken down, so now they just have these big pockets. These big pockets, not much surface area, so you get this bloated looking lung that's filled with air but not much surface area for gas exchange. So that's emphysema, usually from a smoker. It does not look good. Here is cancer, bronchogenic cancer. You can see, so they're showing you this is the right lung. Here's the trachea, and then here is one of this is the right primary bronchus right here. It looks awful. This is all cancer. Not good. Here's another, this is squamous cell carcinoma. This is the trachea. Here is a big cancer. Oops, keep doing that. Go back. Here is a big cancer. It's compressing the right main primary bronchus right here. Probably not getting much air into the right lung here. The left primary bronchus is still open, but this is compressing the right primary bronchus. And this is just kind of cool. Remember we talked about how there is mucus, goblet cells all the way through, pretty much till you get down to the respiratory bronchioles. Right above that is going to be mucus. So if you get dried mucus and you get bronchoconstriction, it is hard to get this mucus out. And if you've ever seen anyone coughing with asthma, they cough. It's violent coughing. They are trying to clear their passageways. And finally, this is dried mucus, and this person basically coughed this up. It is, woo. It's almost a cast of the bronchial tree from all that mucus. And I think that is all I have for you. So that is the end of the respiratory system.